Good morning, everyone, and I'd like to thank Dr. Das for including me in his course. So we all know that canalicular trauma is very common and may occur in all ages. However, the younger adults are more frequently encountered by this trauma. Mode of injury can be direct or indirect. The dog bite in small children is very commonly, we come with a dog bite injury and the canalicular tear. And in lactating mother, the blouse hook injury is very common in these patients. And basically, and can also occur with blunt or penetrating trauma. The cadaveric studies has shown that as the medial canthal tendon encases the lacrimal system, so any injury or like blow with fist to the lateral canthus or malar eminence pulls the medial canthus laterally and thus tears apart it. Along with it, the lacrimal system also tears. So like an avulsion injury, we can have this medial canthal avulsion along with the lacrimal injury. So these injuries can be occult and obvious, and we have to keep a high index of suspicion whenever we see eyelid trauma, especially involving the medial canthus. These are some of the examples of occult tears. So whenever in doubt, pass the probe either in OPD or take the patient to OR depending upon the age. And when we see the probe shining through the soft tissue, it indicates it's a canalicular injury. This patient presented to us with a pencil injury. There were small lacerations which didn't look very basically serious, but however we saw the tear appearing from here, and on observation we saw that it's a direct injury from skin to the sac. So sac was open and need to be repaired. So it's a controversy which canaliculars to repair, whether to leave the upper canalicular. However, as 80% of drainage is through the lower canalicular, but it is believed and it's well written in literature that any canaliculars if injured should be repaired. Timing, early repair was preferred and advocated, but now with experience, it has shown that we can go and repair up to as late as 5 days or 72 hours. So basic principle is to identify the curtain, approximate the curtain around the stent, and retain the stent for adequate period of time. It's always difficult to identify the medial, if the curtain is medial, however the proximal curtain can be identified. So this is a medial curtain which we can see. So if it's not, we are not able to visualize the distal curtain, it's better to put all the tissue in the normal anatomical position. Do not inject too much of the anesthesia, it cause the distortion of the soft tissue, and then pass the probe. If you are not able to identify the distal curtain, you can use the method like passage of air in the pool of water, saline, or you can pass the saline itself from the normal canaliculars, or use the pigtail probe. However, I do not prefer pigtail probe as it has its own, causes a trauma to the canaliculars. The key is the use of high magnification and good illumination. So take the patient under the microscope and see, and in almost all the cases you will be able to find the medial curtain. Stenting can be monocanalicular or bicanalicular if both the canalicular are injured. However, you can do also the monocanalicular stenting if both the canalicular are injured, depending upon your choice. Stent most commonly used are the mini Minoka, which is used, or in bicanalicular Crawford stents are used. If we do not have the mini Minoka, we can go for IV intracath also. This was used earlier, but now as the mini Minoka is easily available, so we prefer to use the mini Minoka stent. So after passing the stent, the approximation with the pericanalicular suturing is very important. It is done with a 8-vicral suture, and then fixate the tube. Though the mini Minoka stent snugly fits into the punctum, however, in a pediatric age group, I prefer to pass 8-vicral sutures through the adjoining tissue so that they do not extrude spontaneously. and we have to take otherwise to the patient under anesthesia again. This is just to show the intracath fixation of the intracath. In this, the stellate is trimmed, the sharp end is trimmed, and it is used as a stellate to pass the intracath. And once we have passed it through the both the cut ends, and then this is trimmed out, and then we are fixating it with the 4O proline suture. The first two sutures are passed through the stent and then to the skin, so that we can pull the stent away from the ocular surface, and we have an up and in traction. So the sutures are passed from the stent and the bolster, skin and the bolster, and then in the medial direction. This is just to show a patient who presented to us with a canalicular tear, but when we saw that there was a slit through the punctum, so the rest of the canaliculus was maintained, but there was a punctum we were not able to appreciate the punctum. So just a minute. So we passed the probe, and after localizing this cut end, and we passed the stent, and we sutured the tissue around it so that we can reform the punctum again. So the one anterior and posterior sutures were, pericanalicular sutures were passed so that we can reform the stent, punctum here. So another patient who had an upper canalicular injury with the lower, upper lid injury with a lower canalicular injury. And after identification of the curtain, the probe was passed. As this was an avulsion injury, so we passed the suture first through the orbicularis with the fibrovicus suture so that we can bring the lid in near to the cut ends and then pass the stent. It's important that we bevel the cut end of the stent so that easily we can pass it through the punctum. This is we passing through the punctum and then through the cut end, and then do the pericanalicular suturing. This is just one of the examples of the patient with the avulsion injury with the canalicular injury. So if we take all the proper measures, we can have a high success rate as high as 95%, and the complications then are with infrequent or minor. So just take a proper steps, identify the structure, and then pass the stent, and maintain the stent for at least 4 weeks so that we can have a good success outcome later on. Thank you.
Dr. Shaloo, it's nice video, etc. But I have just some question to you. So if there is a bicanalicular very close, not a very far away, it is around 3 to 4 mm, then what is your choice? You will go for a 2 stent, or you will go for a single stent?
I'll prefer 2 stents mostly, because I am not so much used to endoscopy, nasal endoscopy. If I have an ENT surgeon with me who can help me in locating the stent in the inferior meatus, then I'll go for the bicanalicular. Otherwise, I prefer for monocanalicular stents.
Yes.
Both are good techniques. You can, according to your surgical experience, you can do.
Yeah, we can. That's another, if sometimes there is a 2 injury. Thank you. So I just, another important point, are you using always a steel? It is, of course, it's very difficult to sometimes, because titanium, if that curtain is very proximal, then I use titanium. So titanium is pretty little smaller, and there is a little good capacity to hold. And so in such scenario, we can use it, the titanium, if it is very proximal.
Titanium for what?
Titanium instrument, forceps,
Yeah.
or that scissor, whatever, in titanium.
You
is
can use
better.
titanium forceps or LIMS forceps, whatever.
Yes,
Yeah.
to collateral injury.
And you should not pass the traction suture, because it will distort the shape of the anatomy of the structures. So minimum anesthesia and no traction sutures.
Absolutely, and you are mentioning about the slit. This is the only challenges with heart. If there is a slit injury, not in a cut, if it is a direct both the cuts are visualized is very, most of the time is easier, but it is a laceration with a slit on that, especially on the medial side, and that's the cause for unidentified on the table. So if any questions from the audience.
Dr. Shaloo, I have a question. Like sometimes they stitch it in the peripheral center. Like if the patient is coming from a far off places, sometimes they do the primary repair over there, and they present late. So sometimes when it's like almost 7 days. And what is your take on that? Like sometimes very difficult to identify now. Once they have done a repair in the peripheral center and sent to a tertiary care center.
Yeah, we counsel the patient that we may redo the laceration, and we'll try to find the medial curtain, and all the techniques we use to find the medial curtain, if either the saline or the trypan blue, or we can. So most of the time it's easy to find, but if it's stenosis, then it's, we have to counsel the patient that they'll have epiphora later on.
Yes, thank you, Dr. Shaloo. And I just address to your question one, that moment that Shaloo. So if there is a inflammation, after 5 days, 7 days, most of the patient reported. In such time, there is a lots of inflammation around. So if there is a more friable tissue, there will be some problems. So in such situation, we can wait for 2 weeks. Moment is healed properly. Or if there is an infection, our aim is to control the infection with proper antibiotic first. Then, if there is a 2 months old, 3 month old, not the issue, we can try our level base. In such scenario, we can just trim that wound little bit. Moment we can trim, it will be again fresh wound. That fresh wound will work like a new wound. So that's another technique. And we should use the microscope